Thank you, everyone. Hope you enjoyed some lunch and had a chance to talk and meet some new people while you're here. And just wow, what an absolutely amazing start to the day today. We've done this a few times now, but I'm really never stopped being amazed at the conversations that come out of this meeting. So thank you to everyone for participating. You're actually going to have a lot more opportunities to do that this afternoon, especially as we move into more of a discussion format for the last few panels of the day. But before we do that, we're going to do something else that I'm also really excited about, and that's a Molecular Tumor Board presentation. So a little bit of background. You've heard a little bit about the TCF TRACK study today. And one of the key elements of the TRACK study is our virtual molecular tumor board. So that group meets once a week to discuss enrolled patients in the study, looking at medical histories, genomic reports, and then ultimately providing a list of treatment recommendations that goes back to the patient and their treating physician. This is a really an all-star team of many different specialties who we're fortunate to get to work with every week for this MTB, and we have 6 members of the MTB here, no 7 today. So Doctors Kurzrock, Nikanjam, Subbiah, Dr. Shreenivas, Dr. Thapa, and Catherine Skefos. As you can see from the slide, this group brings really extensive but very diverse expertise and different specialties to this group. And in addition, they represent 9 institutions across 7 states. So keeping in the spirit of geographic distribution in the TRACK study, so too is our MTB. The weekly meeting that happens really is a testament to the work that goes on behind the scenes by the TRACK study team. So as soon as a patient is enrolled in the study, our team is reaching out to their institution to gather medical records. We're facilitating the transfer of tissue from the treating pathology lab out to Foundation Medicine. We're also sending a mobile phlebotomist to the patient's home to do a blood draw. And once all that information comes back, and especially when the medical records come back, our team extracts that information, and a member of that specific part of the team is here, Jillian Moran, who's here from Dartmouth, to create a medical history that's then presented to the MTB. So today, what we're going to do is talk about a particular patient case, and it's one that will be familiar to everybody here because Alan has very generously offered to have us use his data and his information to drive this conversation today. So thank you, Alan, for doing that. And with that, I'm going to turn it over to Dr. Kurzrock, who will be moderating this discussion.
Thank you. So this is really a pretty amazing MTB with physicians of all different medical oncologists, surgical oncologists, and so forth, from all over the country, some of the best institutions in the country. We have a genetic counselor, we have a pharmacist, really everybody on a Zoom call trying to do what is best for individual patients across the country and letting them stay at home. So we're going to go through, it's pretty much what we do every week in our MTB, but we're going to go through it formally so you have a peek into how it works. And we're going to start with the medical history that Dr. Shreenivas, who I had the pleasure to work with in our precision medicine and rare cancer clinic, and he is now at City of Hope. Are we? It would okay. Yeah. Do you want to come up?
Sure. Thank you, Dr. Kurzrock, and big thanks to Alan for allowing us to share your story. Let me just move the slide. So this is the background. So we're talking about salivary duct carcinoma. It's an ultra-rare and aggressive tumor. Just to give you an idea, almost 5% of head and neck cancers are salivary gland tumors, and around 2 to 5% of salivary gland tumors are salivary ductal tumors. So it's truly rare, ultra-rare. In fact, the prevalence is 1 of a million, 1 individual per million. So we don't see a lot of salivary ductal cancers let alone devise standardized therapies for them. It commonly arises in older men, but as you can see, it can happen in younger individuals as well. More common in some of the larger salivary glands like parotid, but can be seen in other submandibular glands and minor glands as well. 90% are androgen receptor positive, 10% are not. That's a distinguishing feature. Most of these tumors are androgen receptor positive. 16 to 60% are HER2 positive as well. They do come up with certain, specific heterogeneous genomic alterations, and that can sometimes be helpful in devising therapy. There are small case series and some small basket phase 2 studies which have looked at utilizing targeted therapies against HER2 and androgen receptors for these tumors. Now, without further ado, I'll just quickly go over the history. We've heard from Alan already. 53-year-old man, initially diagnosed to have Hodgkin's lymphoma, was radiated and treated back in 1991, had this right neck mass in 2016, which was diagnosed to have salivary duct carcinoma through biopsy. He later had an inferior parodectomy, which was a curative intent surgery followed by adjuvant radiation, and unfortunately had recurrence in 2017 when he presented with mediastinal adenopathy. Biopsy again showed androgen receptor positive disease, and this time he was offered anti-androgen therapy, which led to a complete radiological response. In August 2022, he had recurrence of this disease, this time in lung. Again, a biopsy was done. Some additional markers were checked, as you can see, PD-L1, androgen receptors, and HER2 as well. In addition to that, a unique fusion was also seen. So we know fusions are drivers for a lot of tumors, but this specific fusion, there's no current evidence of oncogenicity or targetability. Unfortunately, imaging studies in February again showed some progression of disease, and most recently in September, he underwent another biopsy which showed recurrence, and we'll move forward. Just to give you an idea of the extent of disease burden he has, you can see here in this picture, the PET scan, the lighted areas are, for the brain are normal activity, but if you go down in the neck area, you would see standard uptake value, which is mildly elevated in some of the lymph nodes there, which could be reactive, but there is high SUV max in lung and some of the mediastinal lymph nodes. So that goes to show his current disease burden. With that, I'll just pass on the dais to Dr. Elvin, who will discuss the genomic alterations. Thank you.
Thank you very much. Can everybody hear me? Okay, great. So we tested 3 tissue samples from the patient as well as 2 liquid biopsy samples over the course of the last 8 years under care here. So the first sample was from 2016, and it was a lymph node involved by the salivary duct cancer. Notably, this was a very high purity sample with over 70% of the nuclei coming from the tumor. And this is really important because what we see on this DNA-based panel is the detection of multiple gene losses. And so we know that these are tumor suppressor genes, which we're going to talk about a little bit later, but a high purity sample is necessary, as well as a test that's able to detect gene losses in order to detect these mechanisms of oncogenicity. What we also determined was it was microsatellite stable. It had a low mutational burden, meaning there wasn't a lot of neoantigens being presented in this case. So the next sample was after that anti-androgen therapy, which was effective. So this was the recurrence and the lung metastatic biopsy. So in contrast to the previous sample, this actually had a low tumor nuclei percentage. So this was somewhere around 1 in 5 to 1 in 6 of the nuclei being coming from cancer. At this level of tumor purity, it's very possible to detect point mutations very sensitively, which is what we detected here, a resistance mutation in the androgen receptor that we see listed here, but we did not see those same copy number alterations that we saw with the higher purity sample. Not that it changed, not that those went away, but it's really an indication of the sample quality. Go to the next slide. When we got a further sample from the lung, a larger, more pure sample that had more than 30% tumor composition, now we see all of the variants coming back up in an aggregate, very complete profile. So not only do we see the copy number losses that we saw in the first sample, which included NF1, P10, and cyclin, CDKN2A and B, but we now also see MTAP loss, which is adjacent to CDKN2A and B genes, as well as that androgen receptor resistance mutation, and a CCND3 amplification, so that's cyclin D3 amplification. So accumulating more copy number gains and losses over time.
And as you can see, many alterations.
Many alterations.
So targeting one may not be as effective as trying to target more than one.
Yes. And one of the things that we have noticed is these copy number alterations may be specifically the types of alterations that accumulate over time and multiple rounds of effective therapy. In contrast to the tissue biopsies, both of the liquid biopsies that were collected for this patient, even though the patient had evidence of active current disease, the fraction of the cell-free DNA in the blood, known as the ctDNA tumor fraction, on both of these samples was very low. So this is a really important thing to keep in mind. Thinking about liquid biopsies, there's real variability in the amount of circulating tumor DNA that is shed by different tumor types. Additionally, it's somewhat related to the level of disease in the patient, as well as the location of the active disease. So the first thing in interpreting a liquid biopsy is noting whether there was actually any ctDNA there that would give us a substrate to detect mutations on. And so in the first collection, we didn't detect any alterations, not even that point mutation in the AR gene. But when this was collected, again, even though there wasn't a high level of ctDNA, the sensitivity for those point mutations is very, very good. And we detected, but we still didn't detect the AR alteration. Instead, we detected an ATM point mutation that is likely actually not related to the tumor, but instead is coming from another contributing part of the body that can shed DNA into the circulation, the bone marrow. So clonal hematopoiesis is something that we discuss a lot in our tumor boards because it can be a confounder and it can contribute mutations that we consider for targeting, but obviously it won't help the tumor if we mistake those mutations as tumor drivers.
Okay, thank you for that thorough review. And next we will have Catherine Skefos, who's our genetic counselor, go over the hereditary aspects.
Thank you. So my role on the Molecular Tumor Board is to assess a patient's cancer type, family history, as well as, of course, the somatic report to determine whether there's any suspicion for hereditary predisposition. Even though a somatic report is not designed to identify germline mutations, they certainly can pop up on somatic reports. And so that's one of my main roles, is to evaluate the mutations on these somatic reports to determine whether there's concern of germline origin. A couple of different points that I consider when evaluating a somatic report include the variant allele fraction, or the VAF. It was once sort of thought that 50% was the target allele fraction for something of germline origin, but we've learned over time that that's not always necessarily the case. The real range may differ based on tumor purity, other genomic events that are going on in the cancer cells themselves. However, we do know that very low VAFs, like we saw with that ATM mutation, are much more likely to be reflective of CHIP or a somatic mutation rather than a germline mutation. I also look to see whether the mutations in a somatic report match the tumor type or family history or cancer type, or whether it's very discordant. So a couple of examples that don't necessarily apply to this case, but are important to consider in general, thinking about things like TP53 mutations. These are very, very common events in cancers, but if you see that in a patient with a childhood sarcoma, one becomes more concerned that that could be germline origin. Also seeing a very discordant mutation, such as a BRCA1 mutation in a patient with an esophageal cancer. There's a higher possibility that that could be an underlying germline mutation. For this patient in particular, we know that salivary gland carcinoma is not known to be associated with germline predisposition. There are case reports of that diagnosis along with hereditary cancer predisposition, but it's certainly not a part of any described hereditary predisposition syndrome. Genes like PTEN and NF1 are known to be somatically mutated in salivary carcinomas, and the reported family and medical history for this patient was not reflective of a phenotype for either of those germline predispositions. So for this patient, no specific germline testing was recommended, although I always say that a patient can consider germline testing if there is a family history that's relevant or if they are interested in learning as much as possible about hereditary predisposition. We learned that this patient did undergo germline testing. A variant of uncertain significance was found in a gene called MUT-YH. That particular gene is associated with autosomal recessive MUT-YH-associated polyposis. So even a single mutation in MUT-YH would not have clinical implications for a patient, but especially since it's a variant of uncertain significance, there was no additional changes to the patient's care based on that finding.
Okay, thank you. Next, we will have Dr. Bicky Thapa, who's a medical oncologist now at Dana-Farber, who will give an overview of some of the findings.
Thank you, Dr. Kurzrock, and thank you, TargetCancer Foundation and Alan for this opportunity. So basically, if we look at the organs, salivary gland, breast, and the prostate, all three are like a similar biological similarity. One is like exocrine gland, all three of them, and they are dependent on sex hormone dependent. So, I mean, even if salivary gland is rare, but we have other cancer which has similar biology but different organ function. We can kind of learn from each other and treat those patients in the rare cancer, especially salivary gland. As Dr. Elvin alluded about the genomics, from the first time and then multiple genomics, we saw that there's a difference. Like initially tumor was completely dependent on testosterone and had excellent response with lowering the testosterone and with the androgen receptor blocker, and which is quite high expressed in the salivary gland. And therapeutically, it controlled the disease for a long time. But with that therapeutic challenge, the tumor transitioned to more resistant one with a mutation in the androgen receptor, and it was androgen receptor in the exon 742C, which is common with the bicalutamide. What it means that now like there's a different clone which is like develop resistant and need to be targeted differently. And also there is an amplification of like cell cycle regulator. So we have to think differently in terms of managing this case. And additionally, when kind of looking at overall tumor management, we look at like do immunohistochemistry to look at the surface of the tumor, which have like a potential target like PD-L1, HER2, and androgen receptors. And in this case, there's a HER2 1+, which is kind of indication of like a trastuzumab deruxtecan, which is approved for 3+, but recently in a breast cancer with a low HER2, like IHC of 1, and as well as 0, which is like a some staining, they had like good response with the progression-free survival. Overall survival is still mature. And androgen receptor, particularly this is important because there are different way of resistance. I will not go into the detail because that's one of my specialty of doing like prostate cancer. So, but particularly with this exon mutation, that can be targeted with a darolutamide, and that is antagonist to that ligand mutation. But bicalutamide is agonist to that. So it will have therapeutic implication. And there are a lot of trials in the prostate cancer where they are targeting the hotspot mutation. Even like some of the mutation are agonists to the enzalutamide, but antagonists to darolutamide. The good part of this novel agent is that it is a different molecularly, and it kind of has potent antagonist, as well as it prevent translocation of androgen receptor to the nucleus. And the more interesting part is that it has very low toxicity profile because CNS concentration is 40 times lower than the enzalutamide and 20% lower than the apalutamide. It is very well tolerated even for 90-year-old patient. So this is a really good drug to attack those point mutation and have like good therapeutic target. Other than that, as there are cell cycle regulator amplification like chromosome 921 hotspot, the locus deletion like CDKN2A and B and MTAP loss. So those are the things that need to be taken into account as well, because that leads to the uncontrolled proliferation. So that can be targeted with the CDK4/6 inhibitor we use common in the breast cancer, and in this case like abemaciclib and palbociclib would be the good one. And MTAP loss, which Dr. Subbiah gonna discuss about, which is like antifolate, and we can use that synthetic lethality, and we have good data from lung as well as cervical and as well as bladder cancer, with we can use like pemetrexed and antifolate to target that. PTEN loss is a common tumor suppressor gene that is common in prostate and other cancers, and in this case, there's a hyperactivation of the PI3K and mTOR AKT pathway. There are different targets, but I think it's going to be toxic with that medication targeting AKT like capivasertib. But I think metformin has some like a role in inhibiting that. NF1 loss is a tumor suppressor genes that kind of suppress the RAS protein. But if it is lost, there is an activation of RAS and MEK pathways, which can be targeted with the trametinib.
Thank you. So I hope you can see how thorough we try to be in going over all the alterations, genomics, immunohistochemistry, what is known in the literature, and so forth. And so next, Dr. Vivek Subbiah, who you've met earlier, and one of the best phase 1 clinical trialists in the world, will talk about possible clinical trials. And so we start always with possible clinical trials. What new drugs are available?
Thank you, Dr. Kurzrock, and thank you, Alan, for sharing this, and Jim and everyone for the opportunity. So again, coming on to clinical trials, right? Dr. Kurzrock and I recently wrote an editorial that the best management for most patients with incurable cancer is on a clinical trial. You should read that. It's published in ESMO flagship journal, Annals of Oncology. Again, this was in response to 3 papers published in JAMA on the role of clinical trials in patients with cancer. Again, we strongly believe that to move the cancer needle forward, I think most patients with incurable cancer should be considered for clinical trials. And thank you so much for the opportunity. Again, I've been to molecular tumor boards in many, many institutions across the world. This is world class. This is better than the best tumor boards. Coming to clinical trials, right? People ask about what is the next new kid on the block in terms of tumor agnostic drugs. And again, although I say every target is a pan target, every drug is a tumor agnostic drug, MTAP deletion is now the new kid on the block and emerging as a tumor agnostic drug. A colleague mentioned a few specific tumors, but MTAP is clearly a tissue agnostic target and seen frequently mutated across multiple tumor types. It is in close proximity, as Dr. Julia Elvin mentioned, to CDKN2A loss. So CDKN2A loss patients also have, some of them also have MTAP loss. So what are the trials for MTAP loss? Again, he mentioned standard of care pemetrexed, sometimes FACP can confer benefit as well. But we have targeted therapies to go after this, right? So we have 2 classes of drugs to go after this, PRMT5 inhibitors and another class called MAT2A inhibitors. Again, the clinical trials are open and actively enrolling at multiple sites, and these are some of the studies that are open in my site in Nashville, and all enrolling for MTAP loss. Again, in combination, the first one is for patients with pancreatic cancer and other cancers in combination with chemo. The second one is in combination with chemo and immunotherapy. And the third one is monotherapy across multiple tumor types as long as the patient harbor MTAP deletion by IHC. Then we have a MAT2A inhibitor. And then another one is interesting because MAT2A works in one domain and PRMT5 inhibitors in another. Again, as drug developers, we'd love to combine that. So another trial is there combining MAT2A and PRMT5 inhibitors. So we have a host of studies here. Some are CNS penetrant, some are not. We will see, may the best win. We want all of these drugs to work in our patients. Thank you so much, Dr. Kurzrock.
Yeah, so I think I hope you see the enormous amount of expertise and thought that goes into every patient from really all over the country, and from really looking at all the different aspects of what is possible. So Dr. Subbiah just discussed the clinical trials, secondary clinical trials, because TRACK itself is a clinical trial. But these are secondary clinical trials of new drugs that are showing very interesting activity in patients. And but we also always try to look at an N of 1 combination of existing drugs as a possibility, because maybe the patient does not live close enough to a clinical trial site, or for whatever reason does not prefer a secondary clinical trial. So the other possibility is to look at all the alterations, not just one alteration, but try to put together a whole picture and how can we combine these drugs. So NF1 loss activates the MEK pathway, and there are 4 MEK inhibitors that are approved. Any one of them can be used. The one that we've used most commonly in this situation is a MEK inhibitor called trametinib that is approved for several different cancers and is part of a tissue agnostic approval, as you've heard before. The patient also has CDK4/6, CDKN2AB loss, which elevates the CDK4/6 pathway, and there are several CDK4/6 inhibitors that are approved. The ones that are most easily available are abemaciclib and palbociclib. And one of the considerations is always, can we get the drug? So these are drugs that we can usually get. Now, the patient also has the PTEN loss, which elevates the AKT-mTOR pathway. And this creates a problem for us. It's a relatively common problem in cancer because both the MEK pathway and the AKT-mTOR pathway are elevated, but virtually every classic MEK inhibitor drug given with an AKT-mTOR inhibitor drug is toxic. So we've published some of these clinical trials, and so have others, and we haven't figured out our way around it. But there are case reports that a drug that is used for diabetes called metformin is an inhibitor of the mTOR pathway, and that it is not toxic when given with a MEK inhibitor. So our suggestion was metformin. Now, going on, the patient has, as mentioned, AR positivity, and but it's resistant. The point mutation is resistant to certain classic drugs, but it's still sensitive to one of the anti-androgens called darolutamide. So essentially, we suggested that the patient get trametinib, abemaciclib, metformin, and the darolutamide. And those drugs can usually be given with pretty good tolerance, but the patient does have some other possibilities. MTAP loss, pemetrexate is a chemotherapy that might target that. The HER2 is 1+, so the drug deruxtecan, trastuzumab, and HER2 is a possibility. And the patient has 2 PD-L1 studies that have been done. One is 0%, which would not be predictive of immunotherapy response, but a different one was 5%. So immunotherapy could be a possibility. We actually suggested the trametinib, abemaciclib, metformin, and the anti-androgen because the patient expressed a preference for drugs that are given by mouth rather than intravenously. And but some of these other drugs could be part of a backup plan. And we've published a few papers using some of these drugs together. So we had some actually quite a bit of safety data, and we've learned how to combine these drugs as well. So this is actually the current treatment that Alan is getting. And one of the things that I'll mention is that we routinely reduce the dose. I mentioned it during my talk. usually start at half dose of each drug and then titrate up to the dose that the patient can tolerate. Because if you can't tolerate the drug, then patient's not going to be able to take it. So I'm going to move on. Dr. Nikanjam is an expert in combining drugs. And do you want to speak to that?
So as Dr. Kurzrock mentioned earlier just now and in her talk, when we're giving novel combinations of drugs, we often don't have phase 1 data to guide us. So what we did a few years ago was look to the literature, and you can see the 5 publications listed here. We looked at data from close to 100,000 patients on clinical trials to see what doses were given in combination. And we came up with a set of rules to help guide us for novel combinations. What we found were that certain classes of drugs, mTOR, PARP, and HDAC inhibitors, tended to be more toxic. Antibodies were less toxic than small molecule inhibitors and cytotoxic chemotherapy. If you have overlapping targets for small molecules, this can also give you increased toxicity. So what we do in the study, as was mentioned, we start most small molecules at a 50% dose. Many antibodies can be started at full dose. Those more toxic classes of drugs like mTOR, PARP, and HDAC inhibitors are often started a little lower, say 25% dose. And then we look to see how the patient is doing and either increase or decrease the dose to optimize tolerability and also efficacy as well. These rules were a starting point. And if we go to the next slide, there are a lot of other factors which can go into dosing, and these were summarized in a commentary that we published in the European Journal of Cancer in 2023. You can see on the left there are multiple other factors affecting dosing. These include age, gender, race, organ function, frailty of the patient, comorbidities, and concurrent medications. And on the right, you can see we have many tools which we can use to help us optimize the dose to provide a truly personalized N-of-1 dosing strategy for our precision oncology approaches.
Okay, thank you. And now we'll hear from Alan.
That's a really nice one. It has everything.
So no one's more surprised than I am that I can actually walk after taking all those drugs, let alone think and talk. But this really does make the case with Dr. Subbiah. He said it earlier this morning about the reclassification of cancer. That it matters not. In 2016, I started in the head and neck clinic and then went to the prostate cancer clinic, and now in 2024 being treated with the addition of other types of drugs that are used within breast cancer. But the biology of the tumor seems to suggest that this tumor will respond to these drugs. So that's why I'm on these drugs, and this makes the case for the reclassification of cancer. I can't thank this esteemed panel enough for their care and their help, and I just would not be here physically if it wasn't for them, and if it wasn't for TRACK, and if it wasn't for my enrollment in this clinical trial. It truly is life-saving, and I can't support it enough, and I think TRACK and the team deserves a round of applause.
Alan mentioned about walking. He's not just walking; he's talking, walking the talk and talking the walk. Thank you, Alan.
So we're here if you have any questions. Last year we ran way over. This year we're under. So there's lots of time for questions now.
Not such a question as a request to have you talk a little bit about the uniqueness of the situation, having Alan here in the room to go over this. And normally you do all this work, you provide all this information, it goes back to the patient, goes back to their treating physician. And then what? So, I mean, in this case, you've got the circle closed. You have Alan here. You know that Alan is following the recommendation. But can you talk a little bit about what happens with these recommendations, and if they're not always being followed, what more can the collective do to make sure that we close more of these circles?
Yeah, so that is a really important question. So this is obviously an outgrowth of the iPredict trial, and conducting a trial nationally is really a little bit different than conducting a trial where you have a leadership position at your own institution. To make this work, we had to institute a way to get the drugs, and we've instituted that at our institution. We instituted that at the University of California, San Diego. It's not that hard. It consists of having somebody, either a pharmacist or a medication acquisition specialist, get the drugs for the combinations. There are various pathways to do that. They're a little bit complicated, but it actually can be worked through. And we can usually get the drugs about, I would say, about almost 90% of the time for the patients. We instituted that, to Jim Palma's credit, as part of the TRACK study, where we have a medication acquisition specialist, actually the person that worked with us at UCSD, that helps patients. But in Alan's case, he actually came to see us in our clinic, and we helped him get the drugs through our system. So you've hit on a key point. You can have big dreams, but if you can't operationalize them, it doesn't matter. And so that's what we've tried to do. And we're not yet ready to analyze the study, but when we analyze it, we will see what percent of patients actually got the drug. But we've put in place ways for the patients to get the drugs. I don't know. Did you want to comment on that, Alan? You might want to comment on that. No.
I think getting access to the drugs clearly is the goal, and in 2024 there exists major hurdles to gain access for a lot of people. I find myself in a very fortunate position to have been able to engage with professionals who are experienced in accessing drugs, but so much is the case in a lot of cases. Many clinics don't have access. Many clinics just can't guide their patients appropriately, and this is the problem that we're finding. Through the work that we're doing here in Think Tank and the ongoing work of TargetCancer Foundation, I hope that this will make it smoother for the patients moving forward.
Thank you.
So the real world challenge is the patient has to be motivated. Again, many patients are, but the physician team has to be motivated. The healthcare provider team has to be motivated big time, right? Again, we do a lot of clinical trials. It's hard to deliver it in the real world. This is what they're doing. This is taking the Hercules and the Hydra story Dr. Kurzrock showed in her first slide. That's what she's doing. They're doing it in real world in the clinic. People say that this is not possible, and they are showing that this is possible. And again, personally, I've had success many times with motivated patients and motivated family members. Again, I mentioned about NTRK and RET. In fact, I had a physician, a colleague of mine, who had a RET positive tumor treated with selpercatinib. Great response. After 2 years, developed NTRK fusion as a resistance mechanism. Talk about zebra. This is a zebra unicorn. And then we made a customized treatment. Again, my colleagues did not like me doing that, so I had to write an N-of-1 study for this. So we customized larotrectinib and selpercatinib on the same patient, did well, developed resistance with an ALK fusion. And we then found out that it's another NTRK drug. Entrectinib targets ALK and NTRK as well. So we combined that. And a year later, unfortunately, there was another solvent front alteration on the NTRK. It's so challenging, and I had to, again, I moved institutions. So again, the patient declined and couldn't make it. So you need to have all components lined up, all stars lined up: patient, doctor, the drugs, everything. The right time, right doctor, right patient, right target, right biology, right clinic, right investigator.
And then I'll make a final comment. As part of these clinical trials, just like any clinical trial, we have to find a way to make drugs accessible to patients, and especially patients at home. But one of the things that people ask me is this scalable? And the answer is no, it's not. But the job of the clinical trial is not scalability. The job of the clinical trial is for us to show that this is effective therapy, and then we need to figure out how to scale it once we show, just like anything else, like bone marrow transplants or cell therapy or a new drug that's in phase 1. In order to scale it, you first have to show in a clinical trial that your plan works, and then we can figure out how to scale it for everybody. You had a question.
Yeah, I'm Jeff Kaufman from the Adenoid Cystic Carcinoma Research Foundation. First of all, just a comment that the teamwork and the commitment from you all is really, really amazing. And it's wonderful, Alan, that you had the support and that you're willing to listen to it. I am very interested in taking 5 or 6 different drugs, the interactions. Were there any cases where there was toxicity and you needed to reduce doses, and what did the team, how could the team decide among the 5 or 6 which to start bringing down? I just love to hear how the mechanics of that worked.
Right, so Alan is actually on 3 anti-cancer drugs and an anti-diabetes drug that a lot of people take anyway, so it's not that many drugs. And we usually will go up to about 4 drugs. So we've published the first results, actually more than once, Nature Medicine, Genome Medicine, of the iPredict trial from UCSD. And I showed it in one of my slides, but actually the toxicity for the combinations was, for the novel combinations, was less than the toxicity for patients who got kind of standard of care. And the reason for that was the standard of care drugs, which are often given in combination regimens, were given at the dose that was the standard of care dose. We didn't modify or personalize that dose because there was a dose that was approved. For the new combinations, as I mentioned, we start at lower doses and then we go to the highest dose that the patient can tolerate well. And so that is probably why there was actually less toxicity. And one of the things we learned from that is that even standard of care drugs, we may have to think about modifying the dose for each patient. The 20-year-old and the 80-year-old do not belong on the same dose, but historically we have done that. We have another publication which is under review, where we show that modifying the dose for these drugs does not compromise their efficacy. So historically, with cytotoxic chemotherapy, more was better, and lowering the dose was bad. But these are targeted drugs, and once they hit the target enzyme, everything beyond that is probably toxicity. And there we can show that we can lower the dose without compromising efficacy, but keep the patients safer and with less toxicity.
I had something to add to that. I would say it's also no different than any other standard combination you give. I had a patient 2 weeks ago on dabrafenib trametinib. He had fevers. They kept coming back. It's like dabrafenib commonly causes fevers, so that's the drug I need to lower the dose on. So we look to see which of the drugs are most likely causing the side effect. And if there's 2 of them, usually we'll have a discussion and say which is likely the stronger cancer driver, which one's more important for the combo, and then try to keep one at the slightly higher dose and then drop the other one. Sometimes it's trial and error that you have to drop one to see if they get better. If they don't, then maybe try the other one. So that's kind of the lowest level of how we adjust the doses.
So another thing to keep in mind is every patient who is walking into our clinic, we do phase 1 studies, is a phase 1 study on its own. The average cancer patient with cancer walking to an oncology clinic is on 8 to 12 different medications. So when we introduce a new investigational or a standard of care therapy, every patient is a combination phase 1 trial on its own. We don't know the drug-drug interactions of these 9 or 12 different medications. So every oncologist is a phase 1 trialist, and giving combinations even without knowing that they're doing NF1 combinations in every patient. So, when they react, when we put 3 or 4 drugs together, oncology drugs, this is like, you guys do it every day. You guys combine it all the time without knowing it. And this is, this may be a reaction mainly because these are all anti-cancer medications.
Yeah, so just to speak to that, Dr. Subbiah is correct. It's the average patient that walks into the oncology clinic is already on 8 drugs because they often have a lot of comorbidities. And the hesitation to combine drugs has really been focused on oncology drugs. And I do think it's a legacy of the cytotoxic chemotherapy era where chemotherapy drugs are really toxic and people are just afraid to combine them. But because we did this 100,000 patient analysis, we figured out some rules for combining drugs, and then we've gained experience doing it. So I think that's really the future. And I do think that personalized dosing is in the future for patients, even for known regimens. It just doesn't make sense to me anymore to give a 20-year-old and an 80-year-old the same regimen. Yes.
Yeah, my name is Jeff Waldron from Mass General. One area that I've focused in is expanded access programs, because I know a lot of pharma companies are reluctant to include late-stage patients or patients with comorbidities on a therapy if it'll maybe harm the chance of drug approval. So it seems like patients, particularly as they say, you have to demonstrate that you have no other therapeutic options. It seems like expanded access programs are key because it gives patients access to a therapy that they might not otherwise get. But equally, it seems like once a drug is approved, the patients that were in the trial probably won't get the drug right away because they're early stage, whereas the ones in the expanded access program really represent the target patient population. So I'd love to hear this tumor board was terrific. So I'd love to hear your thoughts on that.
So I'll just say something about expanded access. So I was kind of involved with the right to try legislation, and it has made it easy, but it's easier. The FDA has actually made it much easier, but it's still not easy. You still have to navigate the pathway. And it's also, if you get an expanded access drug, it's usually one drug. It's not a customized combination. We are right now trying to get expanded access for, I hope I pronounce it right, Dr. Subbiah can correct me, zerletriximab, which is the next NTRK inhibitor. And it's a little hard to navigate, not because of the FDA, but because of everything else that you have to do. The FDA has just really made it easier. I think expanded access is one tool in the armamentarium to get these drugs, but it's not the only tool. There's patient assistance programs. Insurance itself approves drugs for no good reason. I mean, everybody complains about insurance, and surely we've all had terrible experiences with insurance not approving a drug where they should. And we complain that there's some stupid person on the line, but that stupid person can sometimes approve drugs that shouldn't be approved. I would say that a certain percentage, and I would say about 30% of the patients just get the drugs through insurance, even though it's not guideline based. And then we work up to the 90% by other means. I don't know if anybody else has comment about that.
I think that's a great point. I agree. That's for FDA-approved drugs, but for investigational drugs, it's still a challenge. FDA has opened it up. It's easy, Project Facilitate, Right to Try, and all that made it easy. But the paperwork, the institutional paperwork is still a huge hurdle. The institution does not like you. Your boss does not like you doing that. And it's a challenge. So doctors want to do it for their patients. Patients want to get it. But the institutions and the pharmacy teams, they don't have an infrastructure. Each institution should have, again, at least the major cancer centers should have some infrastructure for these sorts of programs. They don't exist. Even in the number 1, number 2 cancer centers, they don't exist. So that is a challenge. So because it puts a lot of pressure and onus on the treating physician who cannot just enact that in real time. Another thing what I've really advocated for with the companies is that, again, we have this rigid eligibility criteria. Many patients may not fit into the eligibility criteria. I've advocated for adding an expanded or compassionate access arm and enroll patients with that same biomarker on patients who do not fit the eligibility criteria. And that might be the real world patients. Again, because of a creatinine clearance of 25, but this patient has an NTRK fusion or a RED fusion or an EGFR exon 20 mutation, the patient is not able to access that specific drug. The patient can be added to that compassionate arm, and that can be analyzed or not analyzed. The challenge is, that safety data needs to be tracked. If something happens, then the pharmaceutical companies are worried that may impact on the long-term approval. That's been the challenge always. But I've been majorly advocating mainly for a compassionate arm together with every study, and that may represent the real world for them, right? It can, fill in so many gaps. Again, I'd like to see more and more of those compassionate arms in studies where patients are enrolled who are not eligible for the study.
I wanted to make a comment. We've been focusing on the action steps that can be taken after testing results are generated. I think one of the things that I've learned within our tumor board is the importance of having a connection to laboratory folks who can actually contextualize those results. So if you noticed the reports that we looked at the beginning, there was an initial report that had a certain set of findings. We tested tissue again after the clinical situation evolved, and it changed, but it changed in a way that could have been interpreted a couple of different ways. So there was a new mutation and a lack of reporting of mutations we saw at the beginning. So one of the really important pieces there was to actually go back, and we've talked a lot about the molecular microscope, but there still is a role for the real microscope, and looking at the patient's tissue sample and saying, okay, is there something that is present in the sample that was tested that we need to consider when we're thinking about the results that we saw. And I think this is a really important case, because if we had stopped with that second report and said, okay, there's just this AR resistance mutation and that's all that there is to find, we wouldn't have gotten that third sample that was a better sample of tissue that allowed us to find the entire complement of mutations that now will open up the opportunity for the MTAP inhibitor trials, the combinations addressing the different cell cycle protein gains and losses. So there's some really kind of nitty gritty, as I like to call it, nerdy technical aspects that actually need to be discussed in these tumor boards to prevent us all from overlooking something that makes all the difference for the patient. So I often recommend even, folks go to multiple oncologists for second opinions, multiple surgeons for second opinions, but honestly, pathology second opinions are also often really useful to get a different set of eyes on the technical parameters to ensure that nothing's getting overlooked.
And that reminds me of an important thing, is that you don't get any of this if you haven't done next generation sequencing on your patient. And so I think that's a critical first step. And my personal opinion, and Dr. Subbiah and I have written about this, is that next generation sequencing should be universal for patients with cancer. It is the diagnosis, and no patient should be without a diagnosis. Dr. Thapa, did you want to comment?
Yeah, just to add Dr. Elvin's point, so for example, HER2 is one of the good target and really good ADCs we have. Recently, we are seeing that next generation sequencing companies also do IHCs, and we can see that IHC for HER2, like PD-L1 and multiple, few things. But I've seen the variability of the positivity in when the pathologist does, and then when we have in the comprehensive sequencing. So it can be positive in one, but negative in other. So we can't rely on the one report. So we have to have another testing done so that we have confirmation. Because ADC, bystander effect, even if there is some staining, we can have like anti-tumor effect on that. So that will make a huge difference in terms of looking at, so therefore like biopsies and liquid biopsies are helpful. The one other emerging detection of the cancer is circulating tumor DNA. In the GU space, I've been using a lot. And I'm finding a patient where there's nothing in the conventional scan was localized, but I'm finding with the circulating tumor DNA quite high. And I do the next generation imaging with the PET scan and all, I could detect the tumor, this thing. So I can prevent patients from going to the surgeries and all unnecessary. So especially in the cases where there are minimal residual disease, we can do like personalized tumor assay and then do circulating tumor. Then if we find something, we can kind of match with the like a PET scan or next generation like imaging, and we see that when there's any residual disease or not. So we are more advancing in the molecular detection of the early detection, or if there is still residual disease or not. In the heme malignancy there is, but solid we are also building that up.
I think we have time for one last question.
Hi, Jeff Goldberg, longtime drug developer and biotech guy. We talked a lot about access to drugs. I want to talk about access to testing, right? So you just raised the point that you need second opinion to pathologists. You need next generation sequencing. But now you need a PET scan. But now you also need circulating DNA. So I live in Boston, great. I can go to Dana-Farber, I can go to NGH, I can get people like yourselves. What if you live in East Oshkosh, Idaho? What if you live in the middle of Mississippi? What if you don't know that you need these things? Talk a little bit about how someone can get access to testing, what level of testing they should be getting. Is that something that we can get universally? And if I don't have access to folks like yourself, what do I do?
So I think that this is what I think should happen. There's something called reflex testing in pathology, where you the pathologist looks at the specimen and automatically orders certain tests to try and elucidate the diagnosis. Pathologists have done reflex testing forever. I think next generation sequencing and certain IHCs like HER2 should be reflex, and they should be ordered as part and parcel of the diagnosis for any cancer patients as a reflex. We actually have at our institution an initiative that is just about to start to do universal reflex testing. But I've been in several meetings now where people have talked about that, and ultimately the way to democratize it is to have it. Just like there's no cancer patient, I don't care where you are in rural, whatever, somebody's going to look under the light microscope to give you a diagnosis. That pathologist, in my mind, should reflexively order an NGS test, and that would be.
Do the pathologists in rural Mississippi agree?
Yes, I do. I'm from there. Yeah.
Alright, so we don't pick on this thing anymore. Let's do it.
Relative with cancer. 6 hours from where you were.
So I don't think we're there with that, with everybody agreeing. Again, the pathologist at our institution, when I suggested it to him, pointing out all the tests that he was doing without me asking me, and I said, why are you doing all these tests? Which I knew the answer to. He was doing it to try and get a diagnosis. And then I said, well, would you do reflex NGS? And he said, come to think of it, yes. So we're not there yet for all pathologists, but I think that's the answer to democratize it. I think we're up in time, so we're all here, so you can ask questions, but I don't want to run into the next group of speakers. So thank you for your attention.